All right, it is my huge pleasure to invite up to the stage Will and Kristen Flannery. You may know them better as Dr. and Lady Glaucomflecken. I think they have on social media something like a combined 4 million followers, which is astounding to someone like me with about 5. And it is a total delight. If you watch their videos, they are entertaining, they're substantive, they're heartwarming, and they're kind. And they bring up really interesting and thought-provoking issues in modern-day medicine. So we are absolutely delighted to present them as the Mary Tyler Moore Vision Initiative's first ambassadors, and we look forward to future collaborations with them.
All right, thank you so much. Just the amount of brain power in this room is astonishing. We've got industry leaders, we have researchers who are just at the cutting edge of treatments and diagnostics for diabetic retinopathy. Anyway, I make TikToks. And Kristen here, she runs the business, really taught me how to actually do some a lot of good with the TikToks. So she gets a lot of credit for a lot of what we do. So I want to thank Robert. Where are you? Right there. Thank you so much for putting this together. This really is awesome. We're so excited to be here. I also do want to give a special thanks to all of my colleagues in retina, all my retina specialist colleagues. Thank you. Thank you for what you do. I mean, somebody in ophthalmology has to work at night. All right, I'm so glad it's you and not me. So what we're going to do today is tell you a little bit about our story and some of the challenges we've been through and what we've learned from those experiences about advocating for patients and families and change in healthcare. And so our story starts in college. We met as juniors at Texas Tech University. We went on to grad school and med school at Dartmouth. So I went to med school. Obviously, Kristen went to grad school. And when I first got there, by the way, she got a much easier time getting in than I did, obviously. But when we first got there, I didn't know what kind of doctor I wanted to be. You know, some med students, they come in, they're like, I'm going to be an orthopedic surgeon who just operates on left knees. All right, that wasn't me. I had to figure that out, what I wanted to do. And on the first day of med school, I was assigned an academic advisor, and she just so happened to be an ophthalmologist. And so I'll never forget our first conversation. She said to me, she's like, "Hi, Will, I'm Dr. Pepin. I'm an ophthalmologist." And I looked at her and I said, "What's an ophthalmologist?" I honestly didn't know. And then she told me that as we got to know each other, she's like, "You know what? You're going to go away for a while. You're going to learn everything there is to know about the human body. You're going to go through all these rotations. You're going to think you want to do all these other specialties. Eventually, you'll be back. You'll realize you want to be an ophthalmologist." And so I did. I went away and learned all the things about the human body. I did all the rotations. At one point, I wanted to be like a cardiologist or a radiologist, and God help me, a neurosurgeon for like a couple days. But eventually, I did find my way back. And I'd never forget the moment, too. So I had my required surgery rotation. That was the most feared rotation for med students, by the way. And so I was on this rotation, and the thing is, you know, I loved being in the operating room. I knew that, but I hated that rotation, that general surgery rotation. Long hours, sick patients, lots of blood, so the opposite of ophthalmology. And I remember the last day of the rotation, you know, I'm standing in the operating room as a med student, you know, for like 5 straight hours. Because these general surgery, these surgeries are super long, right? There's 5, 6 hours. I'm wearing like 20 pounds of lead. I'm just standing there, like motionless. My back hurt, my legs hurt. And I just remember thinking there has to be a better way to do surgery than this. And then I left that rotation and immediately started a 2-week elective in ophthalmology. And the first day I walked into the operating room, somebody offers me a stool to sit on. And that was it. I chose ophthalmology. See, that's the thing. To decide to be an ophthalmologist, there's only 3 questions you have to answer. Do you like surgery? Do you like eyeballs? Do you like to sit down? That's it. Over the course of a career, the average ophthalmologist spends over 800 hours adjusting the height of various chairs. It's one of our favorite activities is sitting down. So I decided on ophthalmology, knew what I wanted to do for my career. We had a young family, we had our first kid. And then toward the end of my third year of med school, I was diagnosed with testicular cancer. And the thing, as many of us know, if you catch testicular cancer early enough, it's pretty easy to treat. And I did. I caught mine very early. All I had to have was an orchiectomy, so I had surgery to remove the testicle. So physically, I was fine. A little off balance, but I was fine. But emotionally, psychologically, this was a huge deal for me. Because I had this disease that I associate with people who are 3 times my age. I was totally healthy 26-year-old. All of a sudden I had cancer. And it's, hearing Adriana talk earlier, it just struck me how difficult it is to be a young person navigating the healthcare system, going to doctor's appointments. Because most of the time you're reminded, this really isn't supposed to happen to you, especially a young adult. Because a lot of attention is paid to little kids, a lot of attention is paid to older adults. But you get this big group of patients in the middle that feel left behind, like they're not as important. It's a very isolating, very lonely experience to be in your mid-20s having medical problems. And then, but I was doing okay. I graduated med school cancer-free, went on to residency at the University of Iowa. And then 4 years after that initial cancer diagnosis, I was now a senior resident. I found a lump in my other testicle. I learned 2 things that day. Number 1, I was part of the less than 1% of people with a primary testicular cancer who get a primary cancer in the other testicle. It's extraordinarily rare. The second thing I learned, I am really good at finding my own testicular cancer. I could make a second career out of it, to be honest. Be a weird thing to do as an ophthalmologist, but it is all just balls, so it kind of makes sense in a way. But there were 2 things that was a pretty low point for me. 2 cancer diagnoses like this, that we had all these questions we had to answer now, because I had to have a second orchiectomy. So, what about hormone replacement therapy? Do I need to postpone residency? Just all these heavy questions. What about our family? We had 2 kids at that point. Were we done? Do I need to bank sperm? All these things. And 2 things helped me get through that moment in my life. One was comedy. So I started an account on Twitter. I called myself Dr. Glockenflecken. And that's because, this is great, because this is like the only audience that actually knows what Glockenflecken is. I chose Glockenflecken because I was like, this is going to be a medical comedy account, so what's the most ridiculous word in ophthalmology? And it was either going to be Glockenflecken or Dr. Pseudophacodonesis. That seemed like a bit much, all right? So I started telling jokes. I was talking about my experience as a cancer patient and as a resident and med student and everything. Just the early stages of this whole Glockenflecken thing. And the other thing that really helped me get through that moment in my life is Kristen. She's there the whole time, helping me and being there for not only me, but our kids, and with me as we navigated the healthcare system, not as a physician, but as a patient.
He's much taller than me. So after his second testicular cancer diagnosis, he graduated from residency. He had an amazing program director who was very supportive, amazing co-residents and fellows. They helped our family get through that without having to have any delays in his education. And so he finished residency cancer-free, mostly because he ran out of testicles. And we moved to Portland, Oregon where he became an attending private practice ophthalmologist, still works in that practice full-time to this day, but you know, full-time for an ophthalmologist is 4 days a week, 8 to 5. So we do have a day that we can be ridiculous and make TikToks, but life was going really well. We had worked so hard. I had been in grad school. He'd been in med school. We had a med school baby. We had a residency baby. We had a med school cancer. We had a residency cancer. We'd had to juggle a lot. And so we were really enjoying, finally, you know, all of our hard work and all of these experiences. They've paid off. Now we get to enjoy the fruits of our labor, right? And be in the nice part of being a physician. And all of that was going very well. Our children were 8 years old and 5 years old in May of 2020, when the night after Mother's Day, I woke up to Will making some very strange sounds at 4:45 in the morning. Now, I am not in medicine. I was in graduate school for cognitive neuroscience. I don't know much I think bodies are gross, and thank you all for dealing with them. But I woke up to him making some very strange sounds, and I thought he was just snoring, and so I just sort of pushed him, you know, hey, wake up and roll over. And he didn't respond to that, and that was unusual. And so I started shaking him harder, and he didn't respond to that. And so I kind of slapped his face a little bit and said his name, and he did not respond to that. And so I called 911. And I spoke to a dispatcher who asked me 2 questions. Is he responding to you? No. And is he breathing normally? No. What I didn't know at the time, but she did in that moment, and so she will always be my hero, is that Will was having a cardiac arrest in his sleep. And I did 10 minutes of CPR on our bed with just the dispatcher and I there together in that experience. Thankfully, we have a very firm bed. I had had a disc replacement in my neck a few months before and was still recovering from that and did not feel confident in my ability to get him off of the bed. And so she had me just take care of it right there. But the paramedics came in. Eventually, as I said, it was May of 2020, so they were in hazmat suits and hoods and just everything, the full gear. And I'm sorry, that's embarrassing because that is my phone alarm. That's going off. So they came in and they took him downstairs and they worked on him and they shocked his heart 5 times, gave him 3 rounds of epinephrine, a dose of amiodarone, and they took him to the nearest hospital. Long story short, everything turned out okay. He arrested on a Monday, 4:45 in the morning, and he was home by dinner on Thursday. And he survived physiologically intact and at least as neurologically intact as he was before. You can only work with what you're given. But that experience has really stuck with me for the obvious reasons, and also because this is a gap in our healthcare system that it took me 2 rounds of cancer and a cardiac arrest to finally be able to put words to. And the thing that allowed me to put words to it, the thing that kicked it all off, was finally his last day in the ICU after the cardiac arrest. One of his nurses, his name is Roger, I couldn't be there, again, May of 2020, but he called me on the phone and he asked me if I was doing okay. In all of our experiences across multiple states, about a decade in time, 2 rounds of cancer and a cardiac arrest, exactly 1 person in the healthcare system ever asked me if I was okay. And I was so taken aback and touched by that I really thought about it afterward. Like, why did that have such a big impact on me? Why did that move me so much? So I started thinking about it, and I wasn't understanding why did I feel so not okay after that cardiac arrest, after all the cancer. Why did I feel so bad? The cancer didn't happen in my body, right? My heart wasn't the one that stopped beating. So what did I have to complain about? And on top of all of that, he survived. He was home. What did I have to complain about? Is how I felt. But I realized after that interaction with Roger that it all happened to me too. It all happened to our kids too, just in a different capacity. But our lives were also changed by each round of cancer and that cardiac arrest. Soon I found a word that allowed me to finally understand the gap that I sat in and what to do about it. And that word is co-survivor. Once I had that term, I had a framework to begin to understand my experience, to begin to talk about it, to begin to find support for it, to find others who were co-survivors and also didn't have that word for it, and we could come together and just have more of a shared experience and a support system from people who really understood. Because let me tell you, as a person on the internet, if I had a nickel for every time someone has commented from behind their keyboard, so much like a woman to take a man's problem and make it about her, comments like these. I do this work because I am not the only one. There are so many of us, especially after COVID, all over the world, who are co-survivors of some kind of medical event. If we are recognized at all, it is often as a caregiver. But we are more than a caregiver. We are more than an extension of the patient's support team. We ourselves are a person that is affected by the very same disease. And it's not either or. Everyone wants to pit survivors and co-survivors against each other and try to decide who gets to win that tug of war. It is not either or, it is both. Patient and family member, survivor and co-survivor, they all need you all. So when a patient has diabetes, their loved ones are also profoundly affected by that disease. More than one life gets changed. And it's so important to hear their stories because it reconnects you to their humanity and to your own. And it reminds you why you do the work you do. It tells people why this work is important, why they should care, why they should fund it, why they should spend their time working on this problem. Storytelling is an amazing tool for advocacy. Because before you are a physician, before you are a researcher, you are a human. And sometimes your words can heal better than your hands. So remember to consider the people that are in the room with your patients, because if they are there in that room, it is not by accident. Their lives are profoundly affected by whatever it is that brought the patient to your clinic or your lab. So be like Roger, ask if they are okay, and offer whatever support or resources that you know might be available to them.
It's always hard to follow her. But here's the thing. One of my biggest takeaways from the cardiac arrest and the whole thing is that when your wife saves your life, you don't win any arguments anymore. But the other thing I realized was that recovering from something like this, it's not just coming home. Like, people think that's the end of the story, but there are so many challenges that you face just beyond what happened in the hospital or what happened to get you to the hospital. One of the biggest challenges we had were when the medical bills started coming in. You know, it happened about 3 weeks afterwards. And it's never just one bill. That would be way too convenient, right? It's like 30 bills from different places, different people for different things. And it's very confusing. It was confusing for me, and I'm a physician. So you can imagine what it's like for our patients, right? Who are trying to recover from whatever it is they're in the hospital for. They're trying to focus on themselves. They should be focusing on themselves, but instead they have to deal with this. They have to navigate this healthcare system with virtually no help. In that experience, as I got all my bills together, I realized I had a ton of surprise bills, like $20,000 that insurance wasn't covering. And it took about 9 months of fighting them to finally get them to cover what they were supposed to cover. And that experience, it changed my content, my comedy. It was around this time that I started making all the videos about the US healthcare system that many of you have probably seen, as a way to just vent my anger and frustration at what I was going through and what my patients go through. And the response I got from those videos was amazing. You know, I've a ton of views, but it was the comments. Thousands, sometimes tens of thousands of comments on a video about prior authorizations. It was all people talking about their own experiences in the healthcare system. And it was like I opened up the floodgates, and everybody had a place to go to vent all their anger and frustration about US healthcare. It just so happened to be my TikTok comment section. And so I realized like I was onto something here. So I started to take more and more complex topics in healthcare, things that are a little bit below the surface, that the public doesn't really have an idea about, like peer-to-peer reviews, like pharmacy benefit managers, like the corporatization of healthcare that's happening, certain legislation, surprise billing, things like that. And I started trying to take those complex topics and distill them down into 2-minute segments. Try to get people to understand, you know, what some of these challenges are. And the same response every single time was just comments, people telling about their own experience. And the biggest lesson it taught me, and one of the biggest things I want you to take away from this, is the value of education when it comes to advocacy. We don't have to know the right answer for things. You don't have to know how to treat that patient's disease. You don't have to know how to fix the healthcare system. But if you can just educate people who don't even know that there's a problem there, who don't know why this is happening, don't know why their retina looks worse, if you can just sit there and just educate them, whether it's in person, on social media, whatever, then you can gain momentum for creating change in whatever it is that you're advocating for. We overlook the value of just education when it comes to advocacy. And it's something that we can all do a lot of. And we're good at it, right? We got the expertise. We just need to get that information out in a way that people can understand. And when I hear all the amazing things at this symposium, all the breakthroughs, the research you all are doing, it's complex. It's high-level stuff, but it's so important. And I think it's even more important that we get those ideas, the things you're doing in this space, get those ideas out there to the public. Show them what we're doing. And that's going to take some creative thinking. Because, like it or not, the average person, they're might not want to sit through like a talk about like artificial intelligence when it comes to like the ellipsoid zone and how it, I barely even know what the ellipsoid zone is. So outside the box thinking when it comes to explaining some of the things that we're doing. And so I want to show you an example of this, about meeting people where they are. So a few months back, the New England Journal came to me with an idea. And I'm just as surprised by that as you are, okay? They said, Dr. Glockenflecken, nobody reads our articles anymore, in no uncertain terms. And their idea was they were going to give me a handful of trials. It said, just pick 2 a month, and if you could just make a skit out of that trial, like a comedy video abstract, as a way to try to open up research to more people. And I was like, this is brilliant. Like I'm not a researcher, but like this is something I can do as long as I don't have to read the entire trial. Like give me a 1-page summary and I'm your man. I got this. And so I did it, and I'm gonna show you one of these videos. It's 2 minutes. We're almost done. I know I'm growing over time, but I wanna show you this because I think it's a great example of thinking outside the box and trying to bring complex ideas to people in a way that's accessible. Let's go ahead and play that. Hey, Ortho. Oh, what up, Bug Bro? Did you see the new study in the New England Journal of Medicine about preoperative antisepsis? Nah, bro, I've been pretty busy over here. Oh, okay, well. It involves fractures. I'm listening. We randomized over 9,000 fracture patients to receive preoperative iodine or chlorhexidine. Different types of topical antisepsis. And cephaloshin. Oh, cool. Anyway, turns out the iodine group had fewer surgical site infections. What kind of extremity fractures were these? Were they open or closed, bro? Bone sticky outie. Oh, both were included in the study, but only the closed fracture group was statistically significant. So according to this study, it would be best to prep all my closed fracture patients with iodine? Yeah. You should also carry around an antibiogram. Here, I brought an extra. Oh, I already have one. Thanks. Oh, okay. Well, see you later. Later, Bug Bro. So far, like people, like there are people that are thinking, like they're saying in the comments, like this is how I want to read all or learn about all the research, that's not exactly what I was going for. But and so the big takeaway here is, while you guys are doing incredible things to try to cure blindness related to diabetic retinopathy, you're doing incredible things, and I want the public to know about these things. And so, in addition to all that amazing work, be thinking about how to get that message out. I know I will, and because I want the world to know what all of you are doing, and just to move this mission forward. So thank you all for your attention.